Okay, so here we have a diagram: trachea, right bronchus, left bronchus. This is going to be the right side of the patient, left side of the patient. The heart is located medially, however, it's to the left lateral, just a little bit of the sternum, and pointing down towards the left leg. Okay, so orientation-wise here, what we have is, let's look at the right lung first. So the right lung has two membranes. The outermost membrane is the parietal pleura, and the innermost membrane is the visceral pleura. Okay, in between the two, there's a pleural space here in which there is a fluid that allows the these two membranes to rub against each other and minimize friction. Okay, it's called the pleural space, and it is a potential space. Nothing belongs in there except for a little bit of fluid. Since this is a coronal view of the patient, here are the ribs. They're coming out at us, the viewer. And in this situation, the left lung is going to be normal, and the right lung is going to have some sort of puncture wound, knife wound, something along those lines. Okay, so the first out of 4 drawings, the puncture wound goes through the parietal pleura, the outer membrane, and the visceral pleura, the inner membrane, and damages the lung tissue. And now we're on to the second diagram. Second diagram looks almost identical. So, patient takes a deep breath in, goes into the left lung, all is fine. Patient takes a deep breath, goes into the right lung, all appears fine. However, over the course of the progression of this patient, the parietal pleura has actually sealed, and that's most probably also because of the intercostal muscles that lay in between each of these ribs. Remember, the intercostal muscles, when they contract, they lift the thoracic cavity up and out. When the diaphragm contracts, it flattens out and brings the volume of the thoracic cavity, and it raises the volume, which decreases the pressure, which causes you to inhale. So anyhow, this air that we're inhaling in can escape because the visceral pleura has not sealed. So this air will then escape into the pleural space here and start to fill the pleural space. Okay. Now, initially, when the puncture wound occurred, the patient was probably just complaining of chest pain. Same deal now, because there have been really no anatomical changes here to affect physiology. So probably just chest pain. However, as we progress, third diagram, the situation of the left lung is still the same. Situation of the right lung, however, the air that has escaped out of the visceral pleura and gotten trapped by the parietal pleura has now gotten trapped inside the pleural space here, the pleural cavity, and it is unable to escape. And what happens is that this air is now putting pressure on what's left of the functioning lung here, okay? And the lung is now starting to collapse. So the patient is going to be complaining of chest pain, shortness of breath, pulse ox is going to be in the basement. The patient's going to look pale because when oxygen binds to hemoglobin, it turns the red blood cells bright red. So the patient is now looking pale, not because they're shunning blood to the core, but simply because they're not carrying enough oxygen, oxygenated blood. Because you have to remember now, we are losing the ability for the oxygen that's in the alveoli to diffuse into the capillaries at a very large level here. We're also losing the ability for the carbon dioxide that's in the capillaries to jump into the alveoli to get exhaled. So carbon dioxide is also building up in the bloodstream. We are now raising our respiratory rate, and we're going to have a decrease of lung sounds. They're going to be diminished on the affected side. So you might sound normal here, little diminished, normal, diminished, normal, diminished, normal. Okay. Now, it's important that we constantly monitor our patient, because if we simply did a chest x-ray at the very beginning of the scenario, okay, here, or even here, we probably would not be able to see the collapsed lung. It takes about 10 to 15% of the lung to collapse in order to show up on a chest x-ray. Okay. Speaking of collapsed lungs, let's take a look at a normal AP chest, anterior posterior chest x-ray, and an abnormal one here. Okay, we know this is an anterior posterior an AP chest for two reasons. Number one, the L here shows that this is the patient's left shoulder. Secondarily, we can see the heart here, and the heart is pointing down towards the left foot. Okay, so major landmarks here. We can actually see the vertebral bodies here. We're actually seeing the spine, and in between the vertebral bodies, there's a little bit of a gap. That is the gap right there. Those would be the intervertebral discs. Okay, so you got the heart here, and right shoulder, left shoulder, and here's the diaphragm. The border between the thoracic cavity and the abdominal cavity. So this is the abdominal cavity here. Okay, very dark, very dark on X-ray means primarily just air. If it's very, very bright white on X-ray, that means it's very dense bone. Okay, so we've got plenty of air here, plenty of air here. Looks a little patchy here, like a little snowy there, probably because of the great vessels that go into and out of the lungs to transport blood to the alveoli and away from the alveoli. Okay, now if we look down here at this lung, we can compare it. You can see the edge, the margin of the lung here has shrunk considerably. That's because the parietal pleura is still out here. This is the visceral pleura. And all this is very, very dark because the only thing that we see in here right now are ribs and air. And what it's doing is this lung has collapsed. It has now pushed the remaining portion of the lung, squeezed it into this region here, which is why we see these dense white snowy areas, because we're concentrating the remaining blood vessels that are in the lung into a smaller area. Okay, so this will show up, obviously this shows up on chest x-ray because this is a chest x-ray. Okay, so you don't simply blow off your patient with penetrating trauma to the chest because the chest x-ray is negative, because it takes 10 to 15% of the lung to collapse in order to show up on a chest x-ray. Okay, so now let's take a look. This is the fourth diagram. Let's take a look at how this collapsed lung has progressed. By the way, collapsed lung, the technical term for that is pneumothorax, Pneumothorax. Thorax because chest, pneumo because air in the chest. Okay, and you might be thinking, well, yeah, there's supposed to be air in the chest. No, think of it as blood. Blood belongs in your blood vessels. If it's out on the roadway because of major trauma, it's useless. If it has left the blood vessels because of internal bleeding and is filling up the belly, that blood is also useless. Well, the air that is outside the lung tissue here is useless. So pneumothorax is the technical term for a collapsed lung. The abbreviations we use are PTX. That means the same thing. Okay, so if we take a look now, left lung, I'll get back to that in a second here. Right lung, almost completely collapsed. All this trapped air in here has completely crushed the margin of the right lung. Here's the visceral pleura, here's the parietal pleura, and we are now at the point where the right lung, the medial margin of the right lung, is now pushing over. A very, very late sign can be tracheal deviation. So because the lung is pushing over here, it'll drag the trachea along with it to the contralateral side, as well as the heart is getting squeezed. So when the heart is getting squeezed, you're going to get less cardiac output. Okay, so now the patient is still going to be complaining of severe shortness of breath, chest pain, heart rate's going to be high. In a minute, we'll talk about why the blood pressure is low, pulse ox is going to be low. There are going to be no lung sounds at all on this side, and the patient's probably going to be cyanotic. Okay, now the reason we're going to have this change of vital signs is because if the heart is being squeezed, that means that, remember, heart rate times stroke volume times resistance equals blood pressure. Well, if the heart is being squeezed and not able to eject as much blood as normal, that means our stroke volume is going to be in the basement. That means our blood pressure is going to be low. In order to compensate for that, we're going to jack up the heart rate and jack up resistance. So this is why our heart rate is high and our resistance is very high as well. So the patient is actually beyond pale. They are now cyanotic. Okay, and we're going to need to release this pressure. And the treatment involves putting a needle in the chest, giving the patient oxygen, and following that up with a chest tube insertion. So we're going to take a look at needle thoracostomy or needle decompression first. Okay, so for needle decompression, we need to know our anatomy. Okay, so along the sternum, if you run your fingers up and down your sternum, you're going to feel an angle, you feel a little bump. That is called the sternal angle. When you take your finger and you move it lateral to that sternal angle, that puts you right on top of rib number 2. Now, the location for a needle decompression or needle thoracostomy is either the second or third intercostal space mid-clavicular. Okay, so that means that when we put the needle in, it's going to be either between the second and third rib or the third and fourth rib, mid-clavicular, right smack in the middle of the clavicle. Okay, we also need to pay attention to whether we put it on where we insert the needle. We can't simply just plop it right here in the intercostal muscle space. That's because there's a neurovascular bundle that runs underneath every rib. So you've got a nerve that runs into that rib, a nerve that runs into that rib, artery, and vein. Okay, so when we needle the chest, you're going to want it to be in this area here along the superior aspect of the inferior rib. So remember, either this is going to be rib number 2 and rib number 3, or this is going to be rib number 3 and this is going to be rib number 4. Either way, you need to run your needle along the superiormost margin of that rib. And this is what it looks like. This stuff out of the way. Okay, here's what a needle for decompression looks like. 3 1/4 inches long. And yes, we bury this entire needle in your chest. Now, because this is a small diagram and a big needle, it's not to scale. But what we do is, here we go. Here's the first, let's go right there. There's the second intercostal space right there. And we're going to go mid-clavicular, and we're going to follow along the superior aspect of the inferior rib because the neurovascular bundle runs there. Okay, so we're going to bury the needle. I can't really do it in this diagram. We're going to put the needle in, okay, and then we're going to withdraw the needle and leave this catheter in place. And this is what it looks like when we arrive at the hospital. The catheter sticking out. Obviously, the rest of the catheter is in your chest cavity. The only thing sticking out is that hub right there. Now, this is fine and dandy. It may look horrifyingly large to you to plunge this in someone's chest. However, you're going to get a lot better air escape because that's the treatment that we need to do. We need to get this air out of the thoracic cavity. So that's why we have to punch a hole in with a needle. What the patient definitely needs, or definitively needs rather, is a chest tube. And in a chest tube, a physician is going to open up the thoracic cavity and insert a tube about the diameter of your index finger into the thoracic cavity. It will then allow the air to escape, and over the course of several hours or a day or so, we're going to hook that chest tube up to negative pressure to suction, and that lung is then going to gradually reinflate, and your patient's vital signs should stabilize.